Hello everyone, welcome to today's live broadcast, The Vital Role of Transformative Diagnostics in Optimizing Antimicrobial Stewardship. I'm Robert Castellanos of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by T2 Biosystems. T2 Biosystems is focused on developing innovative diagnostics products to improve patient health, with 2 FDA-cleared products targeting sepsis and a range of additional products in development. T2 Biosystems is an emerging leader in the field of in vitro diagnostics. For more information, please visit t2biosystems.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window, or submit your problem through the green Q&A button at the lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the C button located in the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would like to introduce today's speaker, Dr. Michael Pfaller. Dr. Pfaller is an accomplished physician, educator, and researchers in the areas antifungal agents and resistance, epidemiology of bacterial and fungal infections, and the role of clinical microbiology laboratory and hospital infection control. He is a co-editor-in-chief of the 11th edition of ASM Manual of Clinical Microbiology and co-author of Medical Microbiology, 7th edition, and has authored 700 articles in peer-reviewed journals. Dr. Pfaller currently serves as Chief Medical Officer at T2 Biosystems. I'll now turn it over to the doctor for his presentation.
Thank you and welcome. It's a pleasure to be able to provide this webinar, and we'll just proceed on with the next slide. Oops. Sorry. Okay. So the outline of the presentation is listed here. We'll first go over briefly antimicrobial stewardship, then discuss rapid diagnostics for Candidemia and Candidiasis and associated antimicrobial resistance issues. We will then discuss T2MR, the technology platform for rapid detection of sepsis-causing pathogens, provide you some case studies of T2Candida performance in clinical laboratories to date, and then discuss an upcoming addition to our portfolio, which will be T2 bacteria and T2 resistance. So first, antimicrobial stewardship. You all are familiar with the concept that early effective treatment improves outcomes in individuals that are suffering from sepsis. Specifically, mortality increases by 7.6% every hour of delay in administering appropriate therapy. And you can see in the graph with the blue bars going down, that's a survival fraction, and the gray bars going up, that's time from the onset of hypotension or clinical sepsis. And of course, we'd like to be at the far left-hand side where we maximize survival and minimize the time to appropriate treatment. Antimicrobial stewardship has several basic principles, and the most important is to optimize the use of antimicrobial agents to achieve the best clinical outcomes while minimizing adverse events and limiting selective pressure that drive the emergence of resistance. Hopefully, by that, we can reduce excessive costs attributable to the suboptimal antimicrobial use. These basic principles are shared by both antifungal and antimicrobial stewardship programs, and certainly are the part and parcel of already established stewardship programs throughout the country and indeed the world. This is a 9-step document that's created by Munoz et al., published last year, and it really, I think, provides a very good template for what to consider in antimicrobial stewardship. And specifically, this one's designed for antifungal stewardship. First of all, you create a collaborative group on mycosis and antifungal treatment, so you have a group with common interests and expertise. Secondly, then, conducting an audit in your institution and identify primary prescribers of antimicrobial therapies. You then want to establish an educational program on sepsis diagnosis and antimicrobial management to assess knowledge gaps. Following that, establish local guidelines, clinical flow charts, order forms, and bundles. Now, certainly there are many of these that are published, but it's imperative that each institution customize these to their own practices and their own clinicians. Set up a daily pharmacy alert for any new antimicrobial prescribed. Obviously, the pharmacy is a key component of any stewardship effort and really is the center for administering these agents, so they are clearly the ones to be alerted first. Implementing rapid diagnostic testing is increasingly a component of antimicrobial stewardship, and although we're just beginning to see some of these being introduced, the effectiveness of such rapid diagnostic testing in guiding antimicrobial stewardship is a very attractive component. We'd like to establish bedside interventions both for diagnostic and therapy. Face-to-face interactions are clearly preferable to other forms of interaction. And you obviously must measure the effectiveness of your interventions, doing predefined indicators, and provide feedback to clinicians, both physicians and nurses, to improve stewardship. Effective stewardship, of course, requires a multidisciplinary approach. Certainly infectious diseases and the pharmacy, especially an ID pharmacist, as well as clinical microbiology are key components here, but other clinicians in terms of hospital epidemiology, critical care, surgery, and hospitalists are very important, as is information technology, and of course hospital administration must support these efforts and must be adequately informed about the program and the advantages of it. There are key elements that I think antimicrobial stewardship must address. And I think of these right now also for antifungals as well as antibacterials. We have diagnostic challenges, and we have to identify high-risk patients, and this could be quite difficult, especially trying to identify the subset at highest risk. And this is because we use old, slow, and less sensitive testing methods as well. There's a lot of inappropriate antimicrobial use out there, and that, of course, is why we have these programs. The delay in initiating appropriate therapy is one that we will specifically address here, but also using the wrong drug when you have resistant species present in your institution, the wrong dose, and this is often the case with anti-infectives that are underdosed. Obviously, if you underdose something, you cut the efficacy considerably, and if you overdose, of course, you have toxicities. The wrong duration, either too short or too long, and unfortunately we find in patients that really shouldn't be on a lot of therapy, they're on therapy far too long. We generally don't truncate therapy too much for those with documented infections, but these are all part of the program to ensure that anti-infectives are used appropriately. Therapeutic combinations is an issue that I think everyone deals with, and the fact of the matter is there are very few therapeutic combinations that have actually been shown to be of advantage. Certainly in patients that are septic and you have potential for a multiplicity of different organisms, therapeutic combinations are used quite a bit. But being able to de-escalate and trim those combinations down to a single effective agent is again another objective for antimicrobial stewardship. And then treating the wrong patient. Certainly we have a lot of evidence that patients that are colonized get misdiagnosed as being potentially infected, and that colonization is erroneously treated, and that should clearly be avoided. Likewise, administering prophylaxis outside of any type of protocolized effort in patient populations where prophylaxis has been documented to be efficacious is important. We do all these things to control antimicrobial use in order to maintain the best standard of care and to control increasing costs as well as resistance. There are many challenges that are faced by antimicrobial stewardship programs, and first and foremost is support from administration. You need to get administration on board because funding for these programs will have to come from the administration, and it's a very complex analysis that I think shouldn't be taken as too lightly, and early on administration needs to be brought into this process. There's resistance to change or adoption of certain practices that haven't been ingrained in the clinical faculty, and that has to be overcome, again, most promisingly with a clinical champion to help those efforts. Inadequate staffing and funding goes right back to administration, and unfortunately we see too many antimicrobial stewardship programs that are understaffed, and so they might fulfill the letter of the law, but they're not nearly staffed well enough to be as effective as they might. We have to be cognizant of regulatory requirements such as CMS funding in administering these programs, and the primary focus on antimicrobial stewardship has to be first on antibiotics, and then there also has to be consideration for antifungal stewardship. Talk now about rapid diagnosis for Candidemia and Candidiasis. The genus Candida contains over 200 species, but most of them have not been identified as human pathogens. There are 5 species that account for approximately 97% of human infections worldwide. They're listed in the pie chart to the right: Candida albicans, followed by Candida glabrata, Candida parapsilosis, Candida tropicalis, and krusei. The exact distribution may vary by geographic location and risk group. For example, in many countries in Europe, Candida parapsilosis is the second most common species, whereas Candida glabrata is certainly in North America and other countries such as Denmark. The exact distribution, the risk groups also are important in this regard. So you see Candida glabrata and Candida krusei in stem cell transplant patients who routinely receive an azole antifungal agent for prophylaxis during periods of neutropenia. We see Candida parapsilosis in patients on total parenteral nutrition and in neonates, and it's an important cause of central line associated bloodstream infection. An isolation of Candida parapsilosis from blood should raise a red flag for breaks in catheter care. We see Candida glabrata most prominently in older individuals, not in neonates to any great extent, but certainly in the older patient population. And Candida tropicalis has long been a major pathogen in oncology patients. Why do we need to identify Candida to the species level? Well, in vitro patterns of antifungal susceptibility vary considerably among the different Candida species. To the right, we have the listing of species. Across the top, we have amphotericin B, fluconazole, itraconazole, voriconazole, and the echinocandins as examples of widely used and often tested antifungal agents. We use the species identification as a surrogate for antifungal susceptibility testing for selecting empirical therapy in many instances because it takes quite a while to do the combined ID and susceptibility testing, and you can predict by the species in many instances. So Candida albicans and Candida tropicalis, as you see on the right, are susceptible to virtually all classes of antifungal agents with rare exceptions. Likewise, Candida parapsilosis, there's a question mark by echinocandins because at least initially it was considered that that might not be the best approach to treat parapsilosis because the MICs are higher, but clearly this species and the subspecies in the parapsilosis complex do respond quite well clinically to the echinocandins. This leaves us with Candida glabrata and Candida krusei as the important multi-drug resistant species that one might encounter clinically. Candida krusei is well known for being intrinsically resistant to fluconazole, but it is susceptible to other azoles like voriconazole, posaconazole, and isavuconazole, agents not listed there. Krusei and glabrata are not optimally susceptible to amphotericin B. They aren't rapidly killed by amphotericin B, and resistant strains have been detected. Candida glabrata is less susceptible to fluconazole than Candida albicans, tropicalis, or parapsilosis. We see their SDD, that's susceptible dose dependent, means that a higher than normal dose of fluconazole needs to be used if you're going to use fluconazole to treat Candida glabrata. But if Candida glabrata is resistant to fluconazole, it will be resistant to all other azoles, including itraconazole, voriconazole, posaconazole, and isavuconazole. This brings us to the echinocandins, which generally are quite active against all of the common species of Candida. We have a concern with Candida glabrata as it is the one species that has been shown to rapidly be able to become resistant to echinocandins while being treated with an echinocandin. So one needs to keep this in mind, and certainly you should know both the frequency of Candida glabrata in your institution and its susceptibility to the echinocandins. The species-specific interpretive criteria for antifungal susceptibility testing are provided by the CLSI, Clinical Laboratory Standards Institute. They have clinical breakpoints as well as epidemiological cutoff values for those organisms and drugs for which there are no clinical breakpoints. If we look at commercially available non-culture-based diagnostic tests for candidemia, there are relatively few. Certainly in the United States, we're left with beta-D-glucan and T2-Candida. In Europe, they have an antigen-based test, the Manan anti-Manan test, as well as at least 3 platforms that utilize PCR and various detection methods, the sepsis test, the Iridica, and Septifast systems. What you see here is the limit of detection in terms of colony-forming units per milliliter for those molecular platforms, and you can see that the sepsis test, Iridica, Septifast platforms all have limits of detection that are well over 10 CFU per mil and many times even higher. The T2Candida has a limit of detection of 1 to 3 CFU per mil. Limited detection in this case means the concentration of organisms in the material tested that can be detected by the test at least 95% of the time. Next column shows sensitivity, and you see sensitivities for beta-D-glucan and Manan anti-Manan in the 75 to 83% range. Both sepsis test and Septifast fall even lower than those two antigen-based tests. And Iridica has published a sensitivity of 81% for detection of Candida in blood. T2Candida, by virtue of a clinical trial performed in 2015, has a sensitivity of 91%. The specificity varies likewise, although all of the systems except for T2Candida have a specificity that's well below 90%. T2Candida, by virtue of over 1,500 hospitalized febrile patients documented to not be infected with Candida, has a specificity of 99%. We look at turnaround time, and we have turnaround times ranging from 3 hours for T2Candida to 24 hours or more for some of the other platforms. Ideally, physicians would like to have a rapid test within 4 hours to really be able to alter their clinical behavior. The tests that we have listed here then for the molecular tests, they're all CE marked. Only T2Candida is FDA cleared as well. Antimicrobial resistance. We've discussed the different resistance profiles that you might see with the common Candida species. In the surveillance efforts that my laboratory has done over the years, there are some certainly concerning emerging resistance issues. Candida glabrata leads the list. Azole resistance is at least 10 to 25% of all isolates, and this remains the greatest concern clinically given the widespread use of fluconazole and other azoles. Remember, I said Candida glabrata, if resistant to one azole, is resistant to all of the azoles. Echinocandins, between 3 and 10% of all isolates of Candida glabrata now worldwide are resistant to the echinocandins. And there's azole and echinocandin co-resistance that can occur in 11 to 58% of azole-resistant isolates, and I'll show you some detail in a minute. Candida parapsilosis, as we said, has elevated MICs intrinsically to the echinocandins, and although clinical response has been relatively favorable, Candida parapsilosis is one species that has been repeatedly found to have be involved in breakthrough candidemias in patients on echinocandins. With azoles, only about 4% have acquired resistance, but that can increase considerably with prolonged azole exposure. And there are recent reports of 40 to 60% fluconazole resistance among Candida parapsilosis bloodstream isolates in California and in South Africa, just to name a couple of scenarios. Candida tropicalis in the United States is generally very susceptible to fluconazole and other azoles. But fluconazole resistance is prominent in countries like Japan and India, where 40% of Candida tropicalis isolates have been shown to be fluconazole resistant. Resistance to fluconazole is increasing in other parts of the world. It's about 4 to 7%. In Europe, it's less than 2% in the United States. But echinocandin resistance is, in the U.S. has recently emerged and is about 2% in our surveillance isolates. So these are organisms that should be of concern to everyone, and maybe in your own institution you have another that could be of concern to you. Exposure to antifungal agents matter. We know that exposure to fluconazole selects for Candida glabrata and Candida krusei. Likewise, exposure to echinocandins really puts folks at risk for infection with echinocandin resistance in Candida glabrata. There are 4 studies listed here, a sizable number of bloodstream isolates of Candida glabrata, and the percent echinocandin resistance ranges from 8 to 18%. That is a figure that almost precludes the use of an echinocandin for empirical coverage of Candida glabrata without susceptibility tests. Certainly if patients have been on an echinocandin prior to documented infection, that is a risk factor for echinocandin resistance. In all 4 of these studies, prior exposure to an echinocandin it has been found to be an independent risk factor for echinocandin-resistant Candida glabrata. Risk factors for treatment failure are echinocandin resistance in all of these studies as well. In the beta study, prior exposure as well as a gastrointestinal disorder was probably a surrogate for echinocandin resistance, but certainly the data shows prior exposure selects for echinocandin resistance. Echinocandin resistance predicts a poor outcome. I mentioned multi-drug resistance in bloodstream isolates of Candida glabrata, and these are 5 studies from the United States in recent years which show multi-drug resistance between 11 and 58% of fluconazole-resistant Candida glabrata isolates. So some would consider Candida glabrata to be always resistant or non-susceptible to fluconazole, and so these kinds of figures are a grave concern, especially since we have few other options besides an amphotericin B product to treat these multi-drug resistant infections. So to summarize resistance for Candida, the greatest concern is still azole-resistant Candida glabrata. The potential for emergence of non-albican species with inherent or acquired azole resistance is always there. Of course, selection for Candida krusei, but also Candida tropicalis and Candida parasilosis are clearly known to become azole resistant in certain settings. Most Candida remain highly susceptible to echinocandins, but emergence of acquired and intrinsic resistance is a concern for the species that are listed there. It's important to note that azole and echinocandin resistance in Candida glabrata does not necessarily come at a fitness cost. And folks, I mention this because folks often connote acquired resistance with decreased fitness and therefore a less virulent or less serious pathogen, and that's not the case with Candida glabrata by any stretch. Non-culture-based diagnostics are especially important in candidiasis overall, and Candida infections range from mucosal infections to deep-seated infections. The serious infections are Candidemia and deep-seated candidiasis. So deep-seated candidiasis is an infectious process that results in or originates from abscesses or other sites of infection other than the bloodstream that may seed the bloodstream or cause local destruction without ever having a peripheral fungemia. In this figure from a paper by Clancy and Nguyen in Clinical Infectious Diseases shows how these overlap. So you can have candidemia without deep-seated candidiasis, where blood cultures are positive and you don't necessarily have seeding of deep tissues or anything. And this is often catheter-related and can be treated quite well on detection with removal of the catheter and administration of appropriate antifungal agents. In some scenarios, though, you may have candidemia with deep-seated candidiasis. This could be the result of catheter-related infection that then seeds end organs such as the kidney, the heart, the brain, the liver, the spleen, etc. Or it could be by virtue of Candida leaching from the gut, establishing a localized infection within the abdominal cavity, and then disseminating from there through the bloodstream. And in some instances, you'll have this deep-seated candidiasis without positive blood cultures. And this is the missing 50% that Clancy and Wynn have written about, and that most folks suspect we might be missing but don't really know the extent of this. And this is really because of the high mortality associated with invasive candidiasis. This is one clinical entity that we should really strive to make the diagnosis. Blood cultures won't do that. The sensitivity in detecting invasive candidiasis of blood culture is poor. It's been estimated at about 38% in a number of different studies. The time to positivity of blood cultures and final identification is also an issue, and certainly may be as long as 48 hours to blood culture positivity, and identification taking another 48 hours if conventional methods are used, much shorter if either proteomic or molecular methods are used. But blood cultures remain at the heart of invasive candidiasis care guidelines. We need that trusted and flawed culture method to really help us identify and detect many organisms that we wouldn't have suspected otherwise. We have rapid culture-independent diagnostic tests, as I mentioned before, that could complement blood culture. And the importance of rapid diagnostic tests is that they provide time-critical information that is essential to limit the mortality and the emergence of antifungal resistance. Here's some data for T2Candida. This is from a paper that we published last year, in which this is subsequent to the clinical trial. So we were able to add additional cases of Candidemia or invasive candidiasis, as you can see in the table below. So we had 33 total Candidemia cases, T2Candida being positive in 31, blood culture obviously in all 33. But then in addition, there are 22 other cases of invasive candidiasis, 12 of which are proven by deep tissue biopsy or other invasive means, and 10 for which they would be listed as probable or possible invasive candidiasis and not proven. Combining those data together, we have a total of 53 cases detected by T2Candida out of 55 total, blood culture detecting only 33 of those 55 for 60%. So just from this analysis, we have substantive data that supports the concerns of Clancy and Wynn that blood culture misses serious infections due to Candida. T2Candida there are other evidence for detecting invasive candidiasis, and we continue to collect cases that report that T2Candida is more sensitive for deep-seated candidiasis than blood culture. In the clinical trial by first author Milanakis, published in CID in 2015, there was one case of intra-abdominal candidiasis, which was detected by T2, missed by 12 consecutive negative blood cultures, and was proven to be a Candida albicans pancreatic abscess upon laparotomy. I've already mentioned the 12 cases of proven invasive candidiasis and 10 of probable or suspected invasive candidiasis that was published in the Future Microbiology paper. And then some case reports from Henry Ford Hospital healthcare system in Detroit presented this year, or in 2016, sorry, 2 cases of empyema where T2Candida was positive but blood culture was missed. One was polyfungemia in a cancer patient that was correctly identified by T2Candida and culture from the infected site, that is the chest cavity, but blood culture only identified one species. Another patient where Candida infection was missed by blood culture but identified by T2Candida, causing therapy to be initiated, and radiography identified abscesses and showed T2 remained positive over weeks with persistent infected abscesses, while blood culture was negative in that patient, obviously correlating to the need to control the source of the infection. And then there's 11 T2 positive, blood culture negative, but culture positive from other non-blood specimens. Many of these have not been fully investigated for invasive disease, but certainly that's the kind of data that we're collecting and following. So T2MR is the technology that we use, and we'll now discuss this technology and its rapid detection of sepsis-causing pathogens. So T2MR uses magnetic resonance, and it's an innovative technology with broad applications. It provides species-specific results directly from whole blood without the need for blood culture. Sorry, culture's missed from that frame. And it provides those results in an average of 4.3 hours, and again with a sensitivity that is well over 90% and highly specific. The published data demonstrates greater than 90% detection compared to 50% for blood culture. This impacts patients. It's now, the T2 platform is now in use at over 150 hospitals in the United States and Europe. There's a proven return on investment where individual customer presentations show greater than 5 times return on investment. And as we'll discuss in a minute, we have a product pipeline that includes not only the T2Candida Panel, the T2 Bacteria Panel, and T2 Resistance Panel. Importantly, T2MR supports healthcare initiatives that are posed by CMS. So we have in blue, both on the left-hand side of the slide as well as in the pie chart, hospital-acquired condition reduction programs, so specifically central line-associated bloodstream infections. We have data that where T2 has been used to help manage these infections, both to detect them or to discount the central line as being the source of infection. We have outcome measures, rapid species identification and early appropriate therapy that contribute to improved outcomes. And then the hospital readmission reduction program, where you, by identifying septic patients before hospital discharge, will contribute to a lower readmission rate. Notably, a paper that's in press in JAMA right now has shown that sepsis is the leading cause of hospital readmission and the most expensive cause of hospital readmission. And finally, Medicare spending per beneficiary, we hope to be able to impact here because misdiagnosing patients negatively impacts the efficiency and cost reduction measures. And we note that with all of this taken into account, in 2017, the maximum amount of reimbursement that CMS will withhold for these measures is 3%. So T2MR provides faster, more accurate detection of sepsis-causing pathogens. I think I've shown you some of that data. So if you look at this timeline, you see T2Candida result positive or negative in 4.3 hours on average. Between 5 and 10 hours, you can ensure the patient's on the right drug, either if they're negative, no drug for an antifungal, or if they're Candida albicans, for example, fluconazole would be a reasonable step-down drug. With routine blood culture, you see at 0 hours, you have symptoms present. You take the blood culture samples. 24 hours, some blood cultures that may be positive. The average time, however, is about 48 hours. Once positive, you can have up to 120 hours where the blood culture results are completed and species identification has been assigned. Shorter times with MALDI or other molecular platforms, and certainly 120 hours for negative blood culture results to be reported, and therefore 27 hours to 7 days for the patient to get on the right drug or get off the wrong drug. So in this cartoon, you see on the left-hand side photos of the cartridge being assembled, placed into the instrument, and press go. That's as simple as it gets. Blood is drawn, the tube is placed on the cartridge into the T2Dx instrument. 4.3 hours, you get species-specific results which enable targeted therapy, as opposed to blood culture, where large amounts of blood need to be drawn, incubating for 1 to 5 days, and then between 1 and 48 hours for species identification on positive blood cultures. So remember, the rapid identification methods that we have and use in the lab nowadays still require positive cultures. So this is a multi-stage slide that will look to show the potential T2 Candida and T2 bacteria impact. This is no culture required approach that gives you pathogen identification in a rapid time frame. In the figures to be seen, you have in green perceived benefits, and below that in orange or gray the other effects. So when you have a patient that has a blood culture drawn, if a T2 is drawn and empiric therapy is started, that's where you start. If it's positive, if T2 is positive, you have faster detection of bacterial fungal pathogens, and it can help physicians adjust the initial treatment earlier. It also gives you an identification of the fungal or bacterial pathogen, and one may influence therapy by adding or subtracting agents that have been part of the empirical treatment paradigm. If T2 is negative, the higher sensitivity of the T2 result will result in fewer false negatives. Negative predictive value in most scenarios would be well over 99%, allowing more patients to receive appropriate rather than inappropriate treatment. So you can adjust treatment, empirical treatment, as need be. De-escalation is important and could be facilitated by T2 results for patients requiring further adjustment to initial treatment, pathogen identification, and possibly narrowing treatment. So for example, if one follows the IDSA guidelines and starts out empirically with an echinocandin, if you detect Candida albicans, one then knows that you could de-escalate safely once the patient is stable, according to the guidelines, with fluconazole. And then susceptibility testing could further streamline those results. If the patient receives the correct treatment earlier, only those require further adjustment will receive susceptibility testing, and then treat to resolution. Finally, discontinuing empirical antibiotics or antifungal agents can be facilitated by a T2 result as well, removing unnecessary antibiotics for patients without sepsis to help save on treatment costs and prevent unnecessary side effects. So now we'll present some case studies. These have been, on this slide, have been presented at ID Week this past year from Henry Ford. At that time, they had tested 142 patients. They found reduced median time to identification from previous years, down from 41.75 hours to 25.25 hours. So T2 testing reduced the time to identification by 16.5 hours. Reduced median time to active therapy. Historically, 39.6 hours to active therapy versus 26.6 hours. So T2 testing reduced time to active therapy by 13 hours. Certainly significant when you have a critically ill patient. And the median ICU length of stay in days was decreased by 7 days. Henry Ford cost savings have been estimated annualized to $2.3 million based on these savings in terms of optimizing treatment of infected patients. Importantly, the all-cause mortality in the T2Candida cohort was slightly higher, 39 versus 33% in the study, but this was not statistically significant and may have some issues with the calculation. This demonstrates key factors for test evaluation as well. In the poster and in the presentation, the investigators really emphasize the importance of pairing the drawing of T2 with a blood culture concerning the timing of antifungal administration so that you can really critically evaluate the performance of this technology in your own scenario. And the rapid turnaround time and the good negative predictive value of T2 should support future antimicrobial stewardship efforts. Additional presentations at ID Week come from 2 other hospitals, Riverside Hospital and Huntsville Hospital. Riverside in California and Huntsville in Alabama. Riverside had 59 patients. 6 were T2Candida positive. 3 of them had positive blood cultures. And they had 53 T2Candida negative patients. None of them had positive blood cultures. There were 8 of those 53 negative patients that were on antifungal therapy, and that was discontinued based on the T2 result and the clinical status in those 8 patients. Of the patients with positive T2 results prior to their positive test results, none were being treated for Candidemia. And Candidemia or antifungal therapy was then administered to 5 of those 6 patients within 6 hours of testing and 100% within 9 hours. So, and the results were available in the hospital reporting system in an average of 6.3 hours. So clearly early detection and identification of fungal infections resulted in focused and appropriate antifungal therapy. In Huntsville, testing 160 T2Candida panel results, 14 were positive, 9 with positive blood cultures. 146 were negative. None of them had positive blood cultures. There was a potential that blood culture missed 64% of patients with Candidemia or invasive Candidiasis. The average duration of antifungal therapy in terms of days of therapy for patients with a negative T2 result was 4 days, and the average time to de-escalation was 42.6 hours. So physicians can certainly de-escalate and stop therapy in the face of a negative result. Reduction in days of therapy and time to de-escalation equated to an estimated $280 saved per patient, and the investigators concluded that the T2Candida panel demonstrated greater sensitivity compared to blood culture to detect Candidemia at their facility and provided a much faster time to antifungal treatment modification. One of our very first sites to report their experience is Lee Memorial Hospital System in Fort Myers, Florida. This was their first 182 patients tested. 7 had positive T2Candida results. The time to appropriate antifungal therapy compared with the period pre-T2Candida was a reduction of 34 hours. It was 40 hours pre-T2Candida, 6 hours post-T2Candida. Antifungal therapy was reduced in a number of patients with negative results. It was avoided entirely in 74 patients. It was discontinued after 1 dose in 27 patients. The length of stay was 13 days in the post-T2 test cohort versus 20 days in candidemic patients in the pre-T2 group. They estimate a net antifungal savings of $195 for every patient tested. Now we're going to mention T2 bacteria and T2 resistance. The T2 bacterial panel will include the following pathogens largely derived from the escape pathogen group: Staph aureus, Enterococcus faecium, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter baumannii, and Escherichia coli. Preliminary limit of detection: 1 to 5 colony-forming units per milliliter, essentially the same limit of detection as for T2Candida. We know blood culture detect bacteremia in about 50% of patients that are clinically suspected of having sepsis, and so being able to identify these key pathogens is clearly important. The pie chart on the right shows the distribution of those organisms, including T2Candida. So you can see that it encompasses a fair proportion of the total, about 60% of the total organisms that might be expected in septic patients. We know in the pie chart shown here that about 60% of patients are appropriately treated by empiric therapy, but 40% are inappropriately treated. And you can see in the table that the pathogens that we're dealing with, this is not even including Candida, all have significantly high mortalities. In fact, these organisms, as well as Candida, lead the list in terms of pathogens that cause mortality in hospitalized patients. By using both T2 bacteria and T2 Candida, we provide species identification for about 60% of sepsis cases, and in combination with empiric therapy, ensure that 95% of patients will be appropriately treated on day 0. Our product pipeline is seen here, so we're not just about Candida. On top we see the fungal stream. We have T2 Candida right now. We intend to develop T2 Candida further to include pan-Candida markers, as well as ultimately detection of FKS mutations for echinocandin resistance. For bacterial, we have the T2 bacteria panel that's in clinical trials right now, and we anticipate being able to provide that commercially later this year. We will also then continue to develop T2 BSI, or bloodstream infection, which has pan-gram negative, pan-gram positive, pan yeast, and coagulase negative staph, and will ultimately develop resistance markers. And we have collaborations with a pharmaceutical company, Allergan, to develop T2 Carba, which will have carbapenemase markers, T2 ESBL, and T2 gram-positive resistance markers, so that we will eventually, to 2018 and beyond, have broad, multiplex, 30-plus species and resistance markers, including pan-pathogen detection, to aid in the fight against sepsis. We also have a line of investigation and development for tick-borne pathogens. So a partnership with Canon Life Sciences has helped us develop the T2 Lyme panel that will be going to clinical trials in the future, and we also intend to then develop an extended tick-borne disease panel. So, to conclude, we hope that antimicrobial stewardship and rapid diagnostics will improve care, both increasing awareness of candidiasis and other serious infections, improve pathogen detection and focused therapy. This should save lives, save dollars, and avoid resistant selection pressure. And with that, we're finished, and thank you for your attention.
Well, thank you for that informative presentation. Before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We're going to try to answer as many questions as we possibly can today. Any questions that we're unable to get to today will be answered offline via email. Our first question for you is, you talk a little bit about your partnerships here. Can you talk more about the partnership with Allergan?
Allergan is very interesting. There are many hurdles to developing effective new antimicrobial agents, and clearly that is certainly something that worldwide is being promoted, and Allergan has really taken up the challenge, and so they have a number of agents, and they're in developing these agents, bringing them to clinical trials. There's a great interest in being able to use a rapid diagnostic test to identify patients for enrollment for the clinical trial within the same day that they're evaluated. Currently, we evaluate patients, they get cultures, and they can't have been on any other antimicrobial agents for 48 hours or less, and that is a barrier to entering patients in clinical trials. So by using a rapid diagnostic test that gives species identification is one way of streamlining those kinds of trials. By including resistance markers, especially for organisms that might be targeted by the drug that the pharmaceutical company has developed, should also be able to facilitate those clinical trials, and indeed may even improve the efficacy of the antimicrobial agents by both identifying the infected patient earlier and getting the appropriate treatment on board earlier as well.
So we're seeing more and more C. orthis in the United States. Are there plans to include that in your panel?
Candida auris. Candida auris is a recently identified species of Candida that has now popped up in a number of different countries, and there are a few cases, around 10 or so, in the United States. The concern about Candida auris is twofold. One is that it seems to be hypertransmissible, so that a patient infected or even colonized with Candida auris effectively contaminates the entire room, much in the way that we've come to see with Clostridium difficile or vancomycin-resistant enterococci. And so the threat for it spreading within a hospitalized environment is great, and the CDC is very concerned about that, and more so because Candida auris has also been shown to be able to readily become multi-drug resistant, much like Candida Glabrata does. So that combination of hypertransmissibility and antifungal resistance in a species that does seem to cause serious infection is a cause for concern. Candida auris cannot be identified reliably by any of the methods routinely used in clinical laboratories right now, including both molecular and proteomic platforms. Both of the MALDI-TOF systems do not identify Candida auris yet unless you have a research use only database, and there you may be able to identify it. Karen Carroll has a short paper in the February Journal of Clinical Microbiology that very nicely describes this. It can be identified by DNA sequencing, and that's how it has been done thus far. So it is a difficult organism. It is misidentified, and we fully intend to have that on a future panel. We just don't have it right now.
And our next question, when blood culture is negative, why are you confident that you're detecting deep-seated candidiasis?
Oh, yes. Oh, yeah. Got it. Well, certainly we've done preclinical evaluations to definitively show the limit of detection, to show that we can get down to 1 colony-forming unit per milliliter. What we know about Candida, and actually it is true about bacterial pathogens as well, is that in most bloodstream infections, the concentration of organisms in blood is well less than 10 colony-forming units per milliliter. And in fact, for most of the targets that we've discussed today, is 50% are less than 1 colony-forming unit per milliliter. We know that we need to culture an adequate volume of blood in order to get at that level of detection, and we need to incubate it for long enough. What is clear is that blood cultures are not performed uniformly throughout the world. There are delays in getting them onto instruments. There are under-inoculated blood cultures, and too few sets are obtained. All of those will undermine the ability to detect low numbers of organisms. With the cases that we've identified thus far, and now we're well over close to 90 cases that I know of that are in terms of being evaluated, where we are positive and blood culture is negative, and we have prior blood culture confirmation or confirmation from deep sites like intra-abdominal abscesses and tissue biopsies, that the T2 result matches that of that other result. So we have certainly look at every case where there's a discrepancy, and we have ongoing studies to evaluate those. And we're very confident that we can detect the low concentration of organisms that are necessary to optimally manage patients and to not include patients as false positives. So our predictive value of a negative is very high, and depending on the prevalence in the population, our predictive value of a positive will be equally high.
And with the time given, it looks like we have time for one more question. I do want to remind our audience that any additional questions will be answered via email. So with this last question here, with LOD of 1 CFU per ml, how do you know that you're not too sensitive?
Well, my answer to the previous question also gets to that issue. With all of the pathogens listed on T2Candida and T2 bacteria, as I mentioned, there is very good evidence that low concentrations of organisms are highly prevalent. And we want to be able to detect those. We want to be able to detect those because they do have clinical consequences. We know if Staph aureus is in the blood, it's causing a problem. We know if Candida is in the blood, it's causing a problem. These are results microbiologically that are not questioned by clinicians in terms of being able to act on them. And I would submit that those platforms that don't get down to 1 CFU per mil are not being used. When you evaluate the literature and you discuss things with colleagues throughout the world, they realize the disadvantages of not being able to detect down to 1 CFU per mil and know that they're missing infected patients, and so can't rely on those diagnostic platforms. So our goal was to have a platform that we get down to that clinically significant level, and we are not detecting DNA-emia. We don't detect free-floating DNA. We detect intact cells. That's where we're different from any of the molecular platforms that are out there for direct detection right now. We don't do DNA extraction. So we're not losing target in the process, and we are not detecting components of an organism that might be the result of dying organisms releasing their DNA from the gut and it getting into the bloodstream. Our specificity is our strongest suit right now, and so just from the clinical trial we have over 1,500 hospitalized, uninfected yet febrile patients that have negative T2 results. And so we have very good specificity database, and we are always increasing our sensitivity database to include those patients with deep-seated infection for which we are often missing or mistreating.
And before we conclude today, Doctor, do you have any final closing remarks?
Certainly. We have a very tremendous opportunity these days for utilizing new technology to save patient lives. Certainly it will save money as well, but to save patient lives and to directly attack the worldwide problem of antimicrobial resistance, effectively we need to have these new technologies used intelligently and cost effectively. And certainly from the perspective of T2 Biosystems, we are working with the community to create treatment plans, care plans, diagnostic plans that will benefit each and every institution that employs the T2 platforms.
Thank you again, Doctor, for your time today. I'd also like to thank our sponsor, T2 Biosystems, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through May 2017. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. And until next time, goodbye.